Welcome back to In the ED Now podcast that makes you an excellent emergency department physical therapist. I'm your host, Dr. Rebecca Griffith, and I'm excited to have with me today Dr. Ryan Martin. Welcome to the show.
Hello, thank you for having me. Appreciate it.
Well, I'm so happy to have you here, and I need you to just give people a little bit of background about who you are and what you do before we get started.
Well, absolutely. Again, my name's Ryan. My background's in physical therapy. Previous to that, I was a biochem guy. So I was like one of the few nerds in the class where everybody was kinesiology, sports med, and athletic training. I was the biochem guy. So I was kind of the nerdy scientist in the back that just loved the microanatomy and all that kind of stuff that happened in there. So as I progressed through physical therapy school, I started my career out in Hawaii, working in standard outpatient orthopedics. Did a couple years out there managing clinics. Huh?
That sounds terrible.
Oh, it was awful. Every day at the beach. Yeah, my clinic was about 5 seconds from the beach. So, and I can always tell a funny story about my one-time surfing, but we'll probably save that for later. Then I moved out to Arizona and managed pain management for a little bit, and I got burned out on that. And somebody told me one time, "Hey, why don't you learn ultrasound?" And at that time, the only thing that I could think of was therapeutic ultrasound. What we think of as a modality for treatment, right? For healing and whatnot. And we know that there's not really good evidence on therapeutic ultrasound, unless you want to heat tissue. But again, efficacy for. And so anyway, I told this person, I said, "You're kidding me. I'm not gonna. Why would I study that? And they said, no, diagnostic." And I said, "Well, can I? Can I do imaging? Can I do diagnostic imaging?" And so, for the next month or two, I did my research for the state of Arizona and how things are growing. So diagnostic MSK ultrasound is in the purview in the State Practice Act. We can do it in the state of Arizona and actually more and more throughout the entire country, to be honest. So I pursued it, and here in town, there was this pseudo residency. So I did about a 1.5 year residency program in MSK Ultrasound under the guidance of Dr. Joel Sellers. He's a sports med physician, Dr. Colin Rigney, physical therapist, OCS, and a professor at AT Still for imaging, and then Dr. Wayne Smith, who basically set up the Andrews Institute. So if you know anything about sports medicine, Andrews Institute is like one of the leading sports med institutes. He basically founded the MSK Ultrasound. So I did a pseudo residency through them for about a 1.5 years, just scanning, learning. And then I took what's known as the RMSK, which is the Registered Musculoskeletal Ultrasound Certification. Since then, I've been doing everything from clinical care to education. So I teach MSK Ultrasound now. I do it in a digital format. I do it live format. But MSK Ultrasound is really my thing. I'm a partner in 5 clinics here in Arizona that are sports med and physical therapy hybrid. So they have both medical and physical therapy working together, using imaging as a, essentially the glue to kind of keep everything together as a bond and a bridge. And so that's what I do. So I'm a partner in clinical practice. I see patients on occasion, like today. And then I teach MSK Ultrasound. So that's me in a nutshell. Is that helpful?
It is. So I think if for people who are listening, they're like, I don't even know what MSK ultrasound is. Like, what is it?
So MSK, musculoskeletal ultrasound, meaning you're looking at things that are outside the purview of obstetrics or rheumatology, or not, I shouldn't say rheumatology, but nephrology. You're not looking at kidneys. You're not looking at thyroids. You're not looking at babies. You're looking at musculoskeletal pathologies, including, bony apparatus, joint pathology, extra-articular stuff. So anything that is soft tissue, we're going to look at, usually within the extremities. That's what MSK ultrasound is.
Okay, so it's kind of a different way to get some diagnostic information without doing CT, without doing MRI, without maybe skipping to X-ray, especially when it's not a bony issue.
Right. So it's another imaging modality, and it's an advanced imaging modality that can be used in conjunction with all the other things that we do as physical therapists. So everything from subjective, objective measurements, we can put this in as another tool for diagnostic criteria. And it can lead towards other advanced imaging if needed, or it can be, you could use that for the imaging purposes for diagnostics. So when you think what it is, especially with physical therapists, we know a lot of special testing, and we have a pretty good idea of how the mechanics or what the pathology may be. But when you
Yeah.
bring MSK ultrasound into the game, you have a better idea, and you can actually pinpoint the severity of what it is.
I think that's pretty cool. I did actually one time I worked at a CrossFit Games, and I did it with a physician, and he had the MSK ultrasound and I had my hands, and then we would bet to see who was right. And it was kind of fun to see there was totally a lot of overlap there. But there were times where I was like totally off base, or there were times when I was like, I don't know, this seems really sketchy. And then we would do the ultrasound and be like, oh yeah, like you need to maybe we need to stop this game for you today because you just sustained a bigger injury than I think you thought you did. So definitely, I've seen it in that circumstance only. And I know here in Colorado, PTs can order imaging. So I'm really like fascinated by this idea of the PT actually performing the imaging themselves. Was the training difficult for that?
The learning curve is pretty steep, and I guess I should mention that yes, as I teach MSK ultrasound, I have an entire program that I teach. We have a mentorship residency that we teach, so it's not an easy program if you're going to try and do it alone.
Okay.
Just like many things that we learn, mentorship and training with somebody that knows what they're doing is imperative. Right? The learning curve is really steep. It's not something that we really learn in school. It's almost like a new language, and it takes time. It does take time. So a lot of people may want to learn this in a weekend, but that's not the case for MSK ultrasound.
Okay, so if somebody's listening to this, whether they're in a clinic or they have their own business, what are the benefits of learning how to do this and going through this whole process yourself? Like, can you bill for that? Does it enhance your business? Is it a marketing tool? Like, tell people like what the practical applications are as a physical therapist doing this.
Sure. Well, the biggest thing is it enhances your diagnostic ability, right?
Mhm.
So in the right hands, just like anything, in the right hands with the right education, this enhances who you are as a physical therapist. Period. It changes the game 100%. So that's one thing. And so people they love that idea, is that they can get better diagnostics, right? And then there's lots of research and literature to show where the efficacy lies, for different pathologies. That's one thing. But another thing is can you bill for it? Well, yes and no. So this is where we need to have more discussions on, what's billable, what's not. Can a physical therapist bill for MSK ultrasound? Yes, they can. Now, will it depend on insurances? Sure.
Okay.
Will it depend on State Practice Act? Yes. And another thing to be considerate of is government agencies such as Medicare, Medicaid, TRICARE. They're not covering it under the if it's rendered by a physical therapist at this point. So a lot of your private practices, or if you're doing anything that's cash pay, obviously you can get reimbursed for it. But yeah, we use it in our PT clinics, and we get reimbursed under PTs, rendering the service. And there are specific codes that you use that are not part of the whole 9-7 groups, that are reimbursable codes for MSK ultrasound. Yes.
Okay. And how do you feel like it's changed your practice?
Oh, I mean, again, prior to MSK ultrasound, I was in, outpatient ortho, and then I worked in pain management. I would say I thought I knew a lot. I really did. I thought, I got this. I know what this is. But when you put an ultrasound on somebody and you look at it and you say, oh, it's humbling. It's very humbling, because you realize that what you thought you know a fraction of, or
Ooh,
what you thought you knew, you just know better. You just enhanced what you did. And so for me as a clinician, I feel that it's only served to improve what I've done. It hasn't taken away anything. It hasn't taken away my judgment calls. It hasn't taken away reasoning skills. It hasn't taken away anything that's helped me as a physical therapist. If anything, it's only improved or amplified what I've done.
okay. I love that. I feel like it's just another tool you can use to help with your critical thinking process, right? But I gotta ask you, all these people that say imaging doesn't matter, and seeing something on imaging doesn't mean it's the source of the pain, like all of that we know, right? Like with MRIs, and the research shows imaging doesn't matter. And I often have to, in the emergency department, tell patients, why they're not getting imaging, because it doesn't matter. So what would you tell people that are like, there's no way I'm going to do that because imaging doesn't correlate with function?
Mm. And we get that, and I hear that. I hear that a lot. Well, here's the thing though, is from diagnostics, is it going to change your outcome? Right?
Yeah.
And that's what everybody wants to know. Is this going to change how I treat my patient? So
Yes.
patient A comes in, right? They have a subacute injury to the shoulder, mild limitations to the shoulder. They have pain and apprehension overhead, reaching behind their back. Your classic, rotator cuff type of pathology. Now you do an ultrasound and you find that there's significant undersurface articular sided tearing and it's holding on by a thread. Is that going to change my clinical reasoning to go ahead and put them through, standard PT treatment? No. So I have medical in-house and I have relationships with medical all through town. It's changed my reasoning skills right there. Is this might need something beyond what I'm going to do, or at least another eye on it. And that's why we work multidisciplinary and we can make that decision. So yeah, it could have changed exactly how I presented with this or how I started my treatment. Or somebody's in there and they're absolutely apprehensive. They have a drop arm, but they have lifted shoulder, all this kind of stuff. And you're thinking to yourself, oh, this thing's completely gone. This thing's a complete total, rotator cuff tear. They're going to go to, whatever. You throw the ultrasound on there and you see the bursas just, completely inflamed, irritated. And is that going to change my thought process? Absolutely. So now I know that there's no full thickness tear. There's no partial thickness undersurface, articular sided tear that I have to go running off and freaking out about it. I can start conservative treatment knowing that I'm not going to damage this anymore. So has it changed the algorithm? Yes, it has. Has it changed the function and how it presents into the clinic? Absolutely. Is it going to be the same way every single time? No. Sometimes I think I know what it is. And throw the ultrasound on there and it is what it is. Sometimes I think it's adhesive capsulitis and they have a cuff tear on top of it. So again, and I'm relating a lot of this to shoulder stuff. This goes throughout the human body. Is we find things that we think we know our algorithms of treatment. I've just streamlined it. I've pinpointed
Yeah.
the actual issue and it has changed what I've done for treatment or what I would have probably done without the imaging on top of it. So for the people that are naysayers or whatever with imaging, and I get it, ultrasound's no different. I find things on ultrasound that don't correlate to what they're talking about. Do I write about it? Absolutely. It's my duty to. But if I
Sure.
find like a bifid median nerve and they're asymptomatic for carpal tunnel, well, I have to realize that that's just an abnormal finding or a aberrant finding is something slightly different or outside the norm. But again, I have to use my critical thinking, as you said. This is not the end all be all. This is just one more tool to help with my critical thinking and give me another choice to where I can move forward with my algorithms.
I love that. So this is a super naive question, so don't laugh at me. How long does it take
To learn or to do the scan?
to do the scan? Because I'm thinking ED, right? And I'm thinking we got to move these patients through here. Don't get me wrong, it takes a year and a half to get a CT scan in the ED, but like I'm just wondering, like, if I can do this and add value
Mhm.
to the ED, like how long is this going to take?
All right. Suspicion of I don't know, a scaphoid fracture. It's a foosh, right? And you just want to rule it in, rule it out really quick. Can you
Yeah.
put that ultrasound there? If you understand what you're looking at, can you look at that scaphoid within 2 to 3 minutes and to make a judgment call? Yeah,
What about
less
plantar
than
fascia,
2 3 minutes.
like a plantar fascia tear?
Plantar fascia tear. I mean, it's going to take longer to take their shoes off.
What about a hamstring rupture?
Oh my gosh, proper dressing is going to be the biggest concern. There is making sure that they're covered up the right way, and that's going to take longer than getting the scan on it. So you could probably see a hamstring tear, and I'll probably tell a funny story. It's not funny, but I'll tell a story here real quick. Is my wife? She called me 2 weeks ago, and I was at one of a sports med clinics, and she said I felt something in the back of my leg, and I said, well, what did it feel like? She said it felt like somebody snapped me with a rubber band. And I said, what were you doing? I was just walking in the garage. I said, oh, and I was at a sports med clinic. I said, come on down. Let me take a look. It took me, I don't know, maybe less than a minute, maybe a minute to scan the hamstring and say, oh, there's a hole. She had a small tear in her semitendinosus that I was able to identify within minutes. Now, if you're triaging and you're having patients in and out and doing all this stuff and you're like, how long does it take? It's either going to take longer to have the system set up and get them, in the proper positioning than to do the actual scan. So if you get a system down to where you have a machine ready, and a lot of these handhelds can be ready within minutes or seconds, and you could be doing that scan, instantaneous results. So again, it comes down to the education and understanding what you're looking for, right?
Yeah. So I think my next question is, how do I know when I want to do that instead of a different type of imaging modality? Like, how do I decide? What's my decision tree look like?
If it's musculoskeletal, yeah.
Yeah, so many patients come into the ED and the physicians just automatically route them for X-ray, right? Like, so how can I disrupt that process by saying, hey, this is going to be quicker, faster, and more effective?
Right. Well, your CPTs, right? So you have all your clinical prediction rules, or your CPRs, I should say. All your CPRs, your Ottawas, your, whatever, your Canadian C-spines, those, right? And so you can, in your head, you're already thinking, they haven't passed these rules, plain film, right? So that part, right? But if they're not falling into the same criteria where X-ray is the first line of defense, you should know that ultrasound for any extremity, if you think that there was pathology in that space that doesn't fall under to the plain film CPRs, you could be using ultrasound right there. And in fact, if you suspect a fracture, here's my question: is how good is ultrasound for determining fractures? I will get you the literature. So you can't see past bone, but you can see the cortical margin. So you can see if there's a step-off fracture, you can see a stress fracture. In fact, if you look at the literature, current literature is what is a better way to look at a stress fracture, acute stress fracture. Is it going to be plain film or is it going to be ultrasound? Well, I challenge a lot of doctors that send it straight for X-rays. Are you going to see every stress fracture right off the bat? Okay. With ultrasound, is it more sensitive? Like, are you going to see it more clearly right off the bat? Yes. And there's markers, there's diagnostic markers where you'll see stress fractures, especially acute stress fractures, immediately. So can you look at bony or osseous pathologies? Yeah, you can. Now, are you going to see them all? Maybe not. Maybe you have to do your quick scan and say, this might warrant additional imaging, or you could say, I see this fracture right here, maybe you get the plain film just to make sure it doesn't have, any other complications in there. That's a clinical reasoning question, right? But, when to use MSK ultrasound, if it comes in and there's acute damage that you suspect musculoskeletal pathology, as long as it's not spinal, you're pretty much have a lot of success with what you're going to find.
Yeah, I'm just thinking about all these folks who are coming in with ankle sprains, for example, who automatically get X-rays and they don't need them. So I'm just thinking like how much this could potentially streamline practice in urgent cares, in sidelines, locker rooms, in the ED specifically. Like in our ED, we have an area that's like a super track area. It's the people who kind of should have gone to urgent care, like those more mild complaints, they're ambulatory, they're sprains, strains, things like that. And the PTs really are managing most of that and making decisions about imaging, different recommendations there. So I'm thinking this could just be a tool that we could use to maybe enhance our care. And it sounds like it wouldn't really provide a delay in care.
No, if anything, as far as like triage and finding the right home for these patients, it's actually over time, once you get better at the protocols, it's actually going to save a lot of the hassle and maybe clear out your emergency department on some of those not as emergent, situations.
Yeah, and I'm thinking too, like ripple effects. So if I've got 40 people in the waiting room and 10 of those people are waiting for an unnecessary X-ray, I've just like speeded those 40 people up.
Yeah.
Or if I'm sending fewer people to CT, that leaves the CT open for the people who have really emergent needs for that type of imaging.
Absolutely.
Because one of the biggest issues in the emergency department overall, right, is operations. It's throughput, it's operations, it's resource availability, it's resource use. So I think if we could use this to help kind of differentially diagnose, to help triage patients a little bit better, to make more appropriate referrals, because that's our other job, is to get patients out of the department.
Right.
Like, my job is to help you leave in the most successful way possible. You might not be going home, but you will leave this department.
Right.
But my job is also to decide what happens next for you. So if I have that kind of capability where I can take a look at a patient and say, oh gosh, no, I actually need to refer you to orthopedics and not physical therapy, or I can confidently refer you just to physical therapy and not orthopedics, instead of just sending out these like mass referrals where access issues are a huge problem, 4 or 5 weeks to get an appointment. I think that would be a little bit more effective. The other thing that I find that patients want when they come into the emergency department is reassurance. And this seems like a really good way to help people with that. What do you think about that?
Oh, absolutely. Absolutely. So when they come in and they think, oh, I did this, I did XYZ, and you do the scan and it comes up negative, and you're confident that it's negative, that's going to help out right there.
Yeah.
Yeah, and I mean, as far as time management and operational, I mean, again, I don't work in an emergency department, so I don't know all the odds and ends and how it works. But I mean, in a multidisciplinary clinic like we have here, we have to make those clinical decisions because the PTs are doing the diagnostics, and they have to decide, am I pushing this through to our medical team, or
Yeah.
am I keeping this within our, conventional PT, or am I actually sending this to one of our partners that does orthopedics? So we have to understand that algorithm, and that's what we teach, is how to understand that. So it's not just, how to do ultrasound scans, it's why to do ultrasound scans. And I think this would fit beautifully as that like little piece into a puzzle for the emergency department.
I think you're absolutely right. And then when we talk to students about evaluate, treat, and refer, evaluate and treat, or evaluate, like making that decision-making process, you're really talking about helping streamline that process so you can more confidently evaluate, treat, and refer, and you know who to refer to. But I'm going to ask you, because there are PTs who are like purists out there and like, we're autonomous providers, we should not be working in partnership with physicians. Talk to me about that, because obviously that's not the model I work in. I work in the most collaborative, multidisciplinary team ever. It's definitely a team sport. But what do you think as far as the direction of PT and our role in the medical model? Should we be these autonomous standalone providers, or are we losing out on providing something for our patients?
Right. Well, I mean, I'm not going to knock, the idea of being autonomous. But I do see, I mean, there's flaws in every system, right? I mean, in the healthcare system, it's not like anything is going to be necessarily perfect, right? And so I don't
Right.
knock it per se, and I don't knock the purist for wanting that autonomy. That's not the route we went. We really feel that the collaborative, effort between medical and physical therapy, and bridging it with imaging, we felt that that was the best that we could do for our patients,
Yeah.
especially in this type of environment, because we are essentially non-operative or non-surgical orthopedic management and sports medicine with rehabilitation. And so to make that work, we couldn't do it standalone. PTs don't do injections, right? And so we have medical here that can help streamline with certain things like platelet rich plasma. I mean, so if you can get somebody in with a specific injection, and again, we could go into detail of what that kind of stuff is, but if we can do specific things under the medical side and parallel that with physical therapy, I wouldn't be able to do that if I was autonomous, right? And I would have to build relationships with outside doctors anyway to make that happen. So no matter how you look at it, standalone PTs, I mean, there's limitations, right? And if you don't understand your limitations, or if you think that you can do everything, I think you could get into trouble. But at the same time, is I'm not going to knock anybody for doing what they do, for how they practice. I
Yeah.
just know how we practice, and I know that we wouldn't survive without a multidisciplinary approach. And the communication between our team, that's where the magic actually happens, is teaching PTs how to talk to medical doctors and how to understand imaging and how to relay the plan of care to where everybody's on the same page. And I'm sure the emergency department is like that, but tenfold. And so for us, it wouldn't work without that collaboration. Do I see the future of PT being completely autonomous? No, but that's my personal opinion.
Well, I would push back a little bit and just say that when you're a top of scope provider, autonomy is more of a mindset than a practice location or a practice model. And I think what you're describing is truly autonomous decision making in collaboration with other providers. So when I hear people say that they don't want to partner with physicians, I get that we don't necessarily want to be told what to do or how to practice. But I think there is magic in being an autonomous provider, a doctor of physical therapy that can truly collaborate, enhance, and streamline patient care through these different models that are available.
Well, I think what you're talking is semantics, right? Is what do we consider autonomous? Here's the thing:
Yes.
is in our practice, our PTs are autonomous. I
Yes.
mean, they are top of scope autonomous. They make clinical decisions and reasoning that maybe some other PTs aren't doing at this level, but we do it in collaboration, 100%. Okay, we haven't. But if you think autonomy is isolation, now we're talking a
Yeah.
difference in definition. No. Okay. So, but if you're talking autonomous in like top of scope and able to make clinical decisions independently, absolutely. But sometimes there's those things that you're like, a second eyes wouldn't hurt, and that's when you get humbled, and that's when you actually become a good practitioner and you're doing your patients a better service.
Yeah, I just had a conversation with somebody about top of scope as a concept because obviously I'm a huge believer in that. And we both agreed that really you don't get to the top, that you're constantly climbing towards the top, right? So it's all a growth process, it's climb, and that's really where that learning comes in. So I think you're absolutely right. I love that. And I love that model. And I love that your providers are really able to collaborate that way. So I've got kind of an unexpected question for you. Have you ever had to send a patient to the ED based on your MSK ultrasound findings?
To the ED,
Yeah.
off of MSK ultrasound. Um, yeah, we've had DVTs that were suspected as calf pain,
Mhm.
and so a quick call has resolved those type of things. So yeah, so sometimes you'll get, and then again, I don't knock any profession, but sometimes you'll get a referral that says calf pain, and the first thing in your head is Wells criteria, or you start thinking of like, okay, what's going on here? Now I put the ultrasound on there, and you're like, oh, okay. Now, even though you don't think of it as musculoskeletal, you have to understand how to differentiate.
Right.
Okay, so during the training of MSK ultrasound, you have to look at every type of mass that's out there, to be an efficient practitioner, because you have to understand what is a spherical, non-vascular versus an asymmetric vascular structure, and where it's palpable to non compressible. You have to know the differences, because you might find something that looks suspicious, right?
Yeah.
I've never had to send anybody out for a cancerous lesion that I've ever found. But I have found things that, well, I shouldn't say that. I have sent people out for lesions that look suspicious, but I've never had anything come back that was terrible. Okay. But for things like DVTs or other things like that, yeah, I've had to send people out, at least have a discussion with a medical provider and say, hey, where do we go with this? Emergency department,
Yeah.
or do not do not pass go, do not collect $200, go see your doc right now. So
I love it. So if there's a PT who's in the ED listening right now and they're like, all right, I'm sold. I want to do this. Where and how do they find you? Where and how do they do this?
well,
And
there's
how
a
do they,
lot of
one more question. How do they even pitch that to their emergency department?
they call me and I'll pitch it to their department.
Love it.
I have no problem with that. No, when you pitch it or when you try and talk it sells itself. Like, it shouldn't have to be a car sale, or it shouldn't have to. It's a necessity. It's a means, right? And it helps augment. It's not a difficult decision when you understand what it can do. When you understand the actual benefits here, it's not a sale. It's just like, oh, it's a no-brainer, right?
It's kind
Um,
of like having PT in the ED. Once you understand the benefits, it's a no-brainer.
Correct, 100%. It just makes sense. And then when you see it in action, then you're like, oh, okay. I see how this works. Now, for people that want to learn it, there's a ton of avenues, right? I teach it, but I'm not the only one. And I'm not going to sit here on a high horse or on a soapbox and tell people they have to come see me. No, there's a lot of programs out there. And if they want to reach out to me, awesome. And if they want to reach out to me to know what the other programs are, I'm more than happy to share. There's enough space for everybody. The RMSK, so the registered musculoskeletal, certification, that's available to PTs, MDs, DOs. It's a select group that can get that. It's through the APCA, so you can go to their website. And they also, and I think this would be something that you'd probably be more interested in, is they also offer something called a POCUS certification, which is point of care ultrasound, which is more bedside and emergency care stuff. And so the requirements for that are much, much less, but it gives you a very specific, focused type of learning, or a focused certification, whereas MSK, the RMSK exam, is very global. So if people were thinking, oh, I want to put this into an emergency department, I would start with POCUS, POCUS, POCUS. And that's through the APCA as well. So they do the RMSK and the POCUS examinations. I have a few friends that have taken the POCUS who are now going through and getting their RMSK.
Okay. Now, I feel like this is like being a PT student, right? You have to see a lot of normal before you know what abnormal looks like. How long did it take you after your training to feel comfortable?
Well, to be honest, I was thrown into a sports med facility for my residency right off the bat, so I didn't see normal. So it was, no, I mean, like normal was in a book, right? Or normal was on my shoulder, and then it turns out I was like, oh, it turns out I have, arthritic AC joint. Okay, all right, moving on. So learning normal was through, repetition with friends and family, to be honest, but I was thrown into a clinic right off the bat. And so it was almost like working in retrograde, like it was almost backwards for me, because I was just seeing abnormal, abnormal, abnormal. And I'm sitting with some of the physicians there. I said, well, what does normal look like? Like you look at these pictures and you're like, okay, well, that doesn't look like that. That must be abnormal. So it took me a while to kind of figure everything out. But a lot of the people that we put through our program, if you look at it base by base and you understand histology and you understand how tissue is supposed to look and you understand the anatomy and you understand like how it, the typical variations, if you can understand those concepts, a couple months into it, you start putting those recognition patterns together and you're like, okay, that's not normal, but what is it? Right. And so they say, what is it, 10,000 repetitions to be an expert? I don't know. But with ultrasound, it's all about repetition and finding a mentor. That's really what it comes down to, because right when you think you know it, it'll throw a curveball. And I'm sure it's like that with a lot of things, but right when you think that you got this down, something hits you in the face like a 2x4. So it was one of the most humbling experiences ever. And I absolutely love it.
I think that's amazing. And I think you definitely still maybe are that biochem nerd just a little bit, because you said histology, and that's not a thing that I thought about for 15 years. And so I had like that little thinking about a little dry heaveness from PT school and taking that class, to be honest.
Well,
I'm the physiology
nerd. PTSD, remember, starts with PT. So
that's awful. Okay. So what parting thoughts do you want to leave people with after this podcast?
Well, I think parting thoughts for this are going to be things such as, don't limit yourself. That doesn't mean MSK ultrasound, but don't limit yourself. And I teach outside the box. And I think as physical therapists, we need to break outside that box, and we have to be bold and we have to be better. And when I say better is we're doing a good job, but we can always do better. And the parting thought is no matter what you do, just be better, right? Do your best.
Yeah. I love that. And I totally agree with you. I keep talking to people about physical therapy is not a location. I'm not an outpatient clinic PT. I'm not an acute care PT. I'm not, we need to be PTs that see our patients in the spaces that they present themselves, and we need to give them the best care that we can. So I really appreciate this as another tool to help bring us a little bit closer to that goal. Thank you for being on the podcast. You've been in the ED now, and you're officially discharged.
Oh, wow. That's a good way to put it. Well, thank you so much. Thank you, everybody out there. If you need anything, reach out.